A clinical case of diabetes mellitus. Clinical presentation of diabetes. In most cases, the patient can be asymptomatic, showing no symptoms except for polyuria, polydipsia, polyphagia, weight loss, weakness, dry skin, ketoacidosis in type 1 diabetes, and most the cases of diabetes reported are discovered while performing urine glucose screening. Symptoms of diabetes. Diabetes mellitus is characterized by thirst, polyuria, blurred vision, and weight loss. In most cases, ketoacidosis is associated with type 1 diabetes, and non-ketotic hypersmolar state associated with type 2 diabetes may develop and lead to stubborn coma in the absence of treatment and death. Often the symptoms are not severe or may be absent, therefore the hyperglycemia or high blood glucose level will lead to pathological and functional changes. Chronic complications of diabetes. First, ophthalmological complications. These include diabetes retinopathy and cataract, represented as microaneurysm in the eye, hemorrhage, oxidates, retinal edema, and if not treated, it will lead to blindness. Second, complications are on the kidney or renal complications. These include diabetic nephropathy, which occurs both in type 1 and type 2 diabetes. Manifested as microalbuminuria, progressive diabetic neuropathy leading to end-stage disease. Infections also are one of the complications in the renal system. Neurological problems. Diabetic neuropathy leading to loss of sensation due to the damage of the nerve fiber with the risk of foot ulcers, amputations, and Charcot joints. High glucose changes in metabolism. High glucose level changes the metabolism of nerve cells and reduces blood flow. It also characterized by sensory and motor and autonomic changes leading to orthostatic hypotension and sexual dysfunction. Cardiovascular defects and cerebrovascular disease include cardiomyopathy and myocardial infarction. Peripheral vascular disease and foot ulcer. This is a complication of diabetes leading to a high incidence of gangrene in diabetes mellitus, where it is about 20-fold higher than control group, due to the presence of ischemia, peripheral neuropathy, and secondary infection. Pre-diabetic patient. These are people who are at increased risk of developing diabetes. These people have impaired fasting glucose test. Normally this test will be less than 100, the blood glucose will be less than 100 milligram per deciliter, but in this group of patients the level will be 100 to 125 milligram per deciliter. This test is done after overnight fast. They also have impaired glucose tolerance test, where it's normally it should be less than 150 milligram per deciliter. In these people, the plasma glucose level after a 75 glucose load will, after 2 hour oral glucose tolerance test, it will be between 140 to 199 milligram per deciliter. Some people may have both impaired fasting glucose and impaired glucose tolerance. Pre-diabetics can be treated or advised to have weight loss and increase in their physical activity. Weight loss and increased physical activity will lead to or prevent or delay diabetes and may cause the blood glucose level to return to normal level. Pre-diabetics are also at an increased risk of developing adverse health outcomes such as heart disease and stroke. Laboratory tests done to know if the patient is diabetic or not. First, glucose urea to detect glucose in urine by a paper strip. This test is semi-quantitative and require normal kidney function for glucose. Ketonuria to detect ketone bodies in the urine by a paper strip, also semi-quantitative test. Fasting blood glucose test, glucose concentration in blood samples obtained at least 8 hours after the last. Fourth test is random blood glucose measurement. Here the glucose concentration in the blood can be obtained at any time regardless of the time of the last meal. Glucose tolerance test. This test is performed by giving the patient 75 grams of glucose with about 300 ml of water after an overnight fast. Blood samples are drawn at 1, 2, and 3 hours after taking the oral glucose. This test is more accurate test for glucose utilization. Oral glucose tolerance test in normal and diabetic subject. As we can see, normal people will the administration of glucose, the blue line, is associated with an increase in the release of insulin, while blood glucose level in type 1 and type 2 diabetes tend to be higher because there is no insulin or insufficient insulin concentration to utilize this increase in blood glucose level. So type 1 blood glucose levels in type 1 tend to be higher than type 2 diabetes mellitus because in type 2 diabetes the pancreas still secretes insulin, but it's insufficient to keep the blood glucose level in the normal range. Glucosylated hemoglobin or HbA1c. HbA1c is formed by concentration of glucose with free amino groups of globulin, which is a component of hemoglobin. Normally, the normal level of HbA1c is between 4 to 6.4% of total hemoglobin. Increase in glucose blood concentration lead to increase in the glycated hemoglobin fraction. Done every 3 months, measure the control of diabetes because it represents the glycemic state during the proceedings or before about 12 weeks. Serum fructosamine, this test is rarely used nowadays, and normally it should be between 1.5 to 2.4 millimole per liter. Revised diagnostic criteria. The most common tests used to detect or to diagnose diabetes are fasting blood glucose level, oral glucose tolerance test, and casual post prandial glucose level. Normally, in normal subject, the fasting blood glucose level should be less than 100, and the oral glucose tolerance test should be less than 140 milligram per deciliter. In pre-diabetics, the fasting blood glucose level can be more than 100 and less than 125 milligram per deciliter. The oral glucose tolerance test, blood glucose should be more than 140 and less than 200. Diabetic patient, the fasting blood glucose level should be more than 126 milligram per deciliter, and the oral glucose tolerance test will be more than 200 milligram per deciliter. Casual measurement of blood glucose in diabetic patient will be more than 200 plus the presence of symptoms. Criteria and the diagnosis of diabetes mellitus. Diabetes mellitus can be diagnosed by performing one of these three tests. Either one, symptoms, if the patient has the symptoms of diabetes and the casual blood glucose level is more than 20 milligram than 200 milligram per deciliter, or by performing a fasting plasma glucose level, which should be more than or equal 126 milligram per deciliter, or by doing the oral glucose tolerance test, which should be more than or equal 200 milligram per deciliter. So the diagnosis of diabetes is done by performing one of these three measurement of blood glucose level, and should be confirmed with a second test. The criteria of diagnosis should be confirmed by repeating the test on a different day. Treatment goal for diabetes. The treatment should relieve the symptoms of the diabetes, reduce mortality, improve the quality of life for the patient, reduce the risk of complications such as microvascular and macrovascular disease complications. Macrovascular complications include coronary heart disease, stroke, and peripheral vascular disease, while microvascular complications include retinopathy, nephropathy, and neuropathy. Treatment goals. In this patient, the fasting blood glucose level should be between 90 to 130 milligram per deciliter. The HbA1c should be less than 7%. Vehicle postprandial glucose level should be less than 180 milligram per deciliter. Blood pressure should be kept and should be reduced to less than 140 over 90 milligram per milligram mercury. Low density lipoprotein cholesterol level should be less than 100 milligram per deciliter. Triglycerides less than 150 milligram per deciliter. High density lipoprotein cholesterol should be more than 40 milligram per deciliter. For women, high density lipoprotein cholesterol goal may be increased by 10. That's more than 50. General approaches for treatment of diabetes. First, we start with the meal planning, medical nutrition therapy. With meal planning and medical nutritional therapy. Second, activity and exercise. Third, medication, regular complication monitoring, self-monitoring of blood glucose, and control of blood pressure and plasma lipid levels. Non-pharmacological therapy or lifestyle modification It has been found that several studies have shown that lifestyle changes can prevent or delay the onset of type 2 diabetes in high-risk patients. These studies including people with impaired glucose tolerance test and other high-risk characteristics. Lifestyle interventions include diet and moderate intensity physical activity. In diabetes prevention program, applying lifestyle modification has been found to delay the development of diabetes in about 58% of the patient over 3 years. First step in treatment of diabetes is diet control. For type 1, regulated insulin administration with a balanced diet. In most cases, high carbohydrate diet 50 to 60%, low fat about 25 to 35%, and low cholesterol less than 300 milligram diet is appropriate. Type 2 diabetes need caloric restriction. Use of artificial sweeteners such as aspartame, saccharin, or nutritive sweeteners such as fructose and sorbitol. These type of sweeteners are now their use is increased, but they are associated with diarrhea in some patients. How does exercise level? Applying physical activity or exercise tend to lower blood glucose level quickly, reduce the hepatic glucose output, reduce the insulin requirement, therefore improve insulin sensitivity in type 2 diabetes, reduces the risk of cardiovascular disease, controls the weight, improves the mental outlook, leading to better control of diabetes. Physical activity, effective exercise on blood glucose level. It has been found that in well-controlled diabetes, applying a physical activity or exercise will lower the blood glucose level. In poorly controlled diabetics, blood glucose and ketone will be increased because of the exercise, and the body needs more glucose to utilize during exercise. So there's increase in blood glucose and ketones levels. If blood glucose level is more than 250 to 300 milligram per deciliter, postpone exercise until control improves. Physical activity performed in the presence of specific complications of diabetes, such as retinopathy. If the patient applies vigorous aerobic or resistant exercise, this may lead to hemorrhages or retinal detachment. In the presence of peripheral neuropathy, the patient has a lack of pain or sensation, therefore this will increase the risk of injury and skin breakdown. So we start treatment with diet and physical exercise. Second, monitor the complications associated with diabetes. This will require eye examination of the urine for albumin, feet examination, blood pressure monitoring, and measurement of lipids in the self-monitoring of blood glucose. This requires that the patient can measure his glucose level to keep it in the normal level. More intense insulin require more frequent monitoring. Pharmacological therapy. Initiation of therapy may depend on the level of HbA1c level. If it is less than 7.5 should be treated with lifestyle modification, that's controlling diet and exercise. If HbA1c is more than or equal 7.5, this patient requires the use of one oral drug for treatment of diabetes. If HbA1c is more than 9%, this may require treatment with more than one agent. Drugs used for treatment of diabetes, these include sulfonylurea, biguanides, alpha-glucosidase inhibitors, meglitidinides, thiazolidinediones, hormone mimetic agent, that's glucagon-like peptide 1 agonist, and dihydropeptidase inhibitors. Some oral antidiabetic drugs are used in combination. These drugs usually used alone or in combination. Sulfonylurea include tolbutamide, glipizide, and globride. They act by stimulating release of insulin from increased amount of insulin released from beta cells in the pancreas. Adverse drug reactions associated with sulfonylurea include hypoglycemia and weight loss, nausea, vomiting, heartburn, weakness, and numbness of extremities. A glipizide given 30 minutes before meal. Globride given once daily with breakfast. Avoid alcohol drinking during treatment with sulfonylurea because it may lead to sulfiram-like reaction. If the blood glucose level is normalized with sulfonylurea, it's okay. If not, add another oral diabetic drug such biguanides. This group include the metformin. It acts to reduce the hepatic blood glucose level and increase insulin sensitivity in the muscle and fat cells. May cause weight loss, decrease triglycerides, and low density lipoprotein cholesterol. Adverse effects include gastrointestinal metabolic test, lactic acidosis with kidney failure. Usually given with meals, stopped 48 hours before and after radiology study that use iodine. Monitor renal function during treatment with metformin. Metformin, it has been found by the Diabetes Prevention Program. Metformin reduced the risk of developing diabetes by 31% over 3 years. Metformin is usually effective in younger and obese people, those between 25 to 40 years of age who are overweight. Metformin is effective in reducing both the blood glucose level and body weight. Less effective in older people who are not has an overweight or obese. Alpha-glucosidase inhibitors, these include acarbose and meglitide. These drugs delay carbohydrate digestion and absorption in the GIT. Adverse effects mainly bloating, flatulence, abdominal pain, and diarrhea. Monitor the liver function during treatment. In the Stop Non-Insulin Dependent Diabetes mellitus trial, alpha-glucosidase inhibitors has been found to reduce the risk of developing diabetes by 25% over 3 years. Meglitinides, زي الناتaglinide, act in a similar way as sulfonylurea to stimulate the insulin release from the pancreas, has a short duration of action and reduces the potential of hypoglycemia. Adverse reactions: upper respiratory tract infection, headache, rhinitis, bronchitis, back pain, and hypoglycemia. Usually given 15 to 30 minutes before thiazolidinediones, such as bioglitazone. They decrease the insulin resistance and increase the insulin sensitivity in the muscle and fat tissue. Adverse reactions: fluid retention, increased risk of heart failure, weight gain, and increased fracture risk. Monitor the liver function, because it has been found one of drug of this group has been found to be hepatotoxic and withdrawn. Reduces the blood level reduces the blood level of some oral contraceptives. Glucagon-like peptide 1 receptor agonists, such as exenatide and liraglutide. These drugs has been found to reduce the plasma glucose level through several mechanisms, including increase in insulin secretion, increase in beta cell mass by decreasing lactosis and increasing the formation of new cells, suppression of postprandial glucose level, decreasing glucagon release, slow gastric emptying rate, and has a central effect to cause loss of appetite centrally. Side effects: mainly GIT, weight loss, and they have the disadvantages of being injectable and not available as oral preparations. Dipeptidyl peptidase 4 inhibitors, gliptins, زي sitagliptin و saxagliptin. These drugs inhibit the enzyme dipeptidyl peptidase 4 enzyme, which degrade glucagon-like peptide 1. Therefore, they increase the endogenous concentration of GLP-1. They tend to decrease the postprandial glucose exertions, increase the insulin secretion, and decrease the glucagon level. They have the advantages of being oral administered drug, and they have a low incidence of low hypoglycemia and gastrointestinal side effect. They are well tolerated and weight neutral. Side effect: mostly high risk of infections, such as nasopharyngitis, upper respiratory tract infection, acute pancreatitis, and hypersensitivity reactions. Pharmacological therapy of diabetes mellitus usually started with lifestyle changes or modification, that is controlling the diet and performing some sort of physical activity. If the level of plasma glucose level is not controlled, then the treatment pharmacological therapy depends on the level of HbA1c. If it's less than 7.5%, start the treatment with one drug or oral monotherapy. If it's more than or equal to 7.5%, start the treatment with 2 drugs. If the level is more than 9% with no symptoms, start the treatment with 2 drugs, or 2 to 3 drugs can be used for treatment of the diabetes. Usually, if monotherapy is not effective, you add another drug, and if it's not effective, we add a third drug. reduction of HbA1c to less than 6.5% in 3 months. If the goal is not achieved in 3 months with 2 drugs, or increase the number of drugs used for treatment of diabetes. Oral treatment of diabetes mellitus with anti-diabetic drugs. If glycemic control is not achieved with diet and physical exercise, this means that the HbA1c is more than 6.5%. Oral fasting blood glucose level is more than 126 milligram per deciliter, or random plasma glucose level is more than 200 milligram per deciliter. Then at this stage we start using oral anti-diabetic drugs and add 1 drug to the lifestyle modification. In presence of a marked hyperglycemia in a newly diagnosed symptomatic type 2 diabetes, oral anti-diabetic agent can be considered with lifestyle. As first-line therapy in obese type 2 diabetes, it's usually recommended to give metformin, acarbose, or thiazolidinediones. Non-obese type 2 diabetes usually started with metformin or drugs that stimulate insulin secretion, such as sulfonylurea. Metformin is the drug of choice in overweight or obese patient because it tends to control or reduce the body weight. Thiazolidinediones and acarbose, they can be used as alternative to metformin in patients who cannot take the metformin. If monotherapy fails to reduce the plasma glucose level, combination of thiazolidinediones, acarbose, and metformin is recommended. If the target is not achieved with this drug combination, then insulin secretogens may be added, such as sulfonylurea. So the treatment, you start mainly with metformin, then metformin or acarbose or thiazolidinediones as first line of drug therapy. If treatment fails, we can use drug combination of these drugs together with drugs that stimulate insulin. Metformin, it's the first choice for treatment of type 2 diabetes because this drug has a high efficacy, low risk of hypoglycemia, and reduce body weight combined with low cost. Metformin, if not contraindicated and if tolerated, is the preferred initial pharmacological agent for type 2 diabetes. Combination of oral anti-diabetic drugs. Combination is indicated in one newly diagnosed symptomatic patient with HbA1c of more than 9%, or patient who are not reaching the targets to reduce the plasma blood level after 3 months of combination therapy for type 2 diabetes usually starts, as we said before, drug of choice to start for treatment with is metformin. Metformin can be used with either sulfonylurea, thiazolidinediones, dipeptyl peptidase 4 inhibitors, or glucagon-like peptide 1 receptor agonist. In the late stages of type 2 diabetes, insulin can be also given. Each new class of insulin agent added to the initial therapy. It usually lowers the HbA1c by 0.9 إلى 1.1%. Combinations agent, these are commercial preparation available in the market containing two drug combination of anti-diabetic drugs. Combination of sulfonylurea with metformin represent an effective combination in lowering plasma glucose level because sulfonylurea tend to increase the insulin secretion, and metformin will decrease the production of glucose from the liver. Sulfonylurea is an old group of drugs available in the market for a long period, so it has extensive experience. Sulfonylureas tend to reduce microvascular risk and represent an economical approach for treatment of diabetes, type 2 diabetes. Glimepiride is the preferred drug from the sulfonylurea to be used because it improves the relative insulin secretory defect, has a high efficacy, leading to reduction in HbA1c by 2.5%, minimal hypoglycemia and weight gain. It has pleiotropic benefits, being antioxidative, anti-inflammatory, and angiogenic properties. So from the sulfonylurea, glimepiride can be used as combined with triple combination therapy. Usually we start with metformin, add a sulfonylurea, and you can add a third drug if the blood glucose level is controlled, alpha glucosidase inhibitor. The rationale for using or adding alpha glucosidase inhibitor for this combination is that it reduces postprandial glucose excursions, do not produce hypoglycemia, non-systemic, or reduced, sometimes they say that it reduces cardiovascular events. The main mechanism for alpha glucosidase inhibitor is to reduce absorption of carbohydrates by preventing their absorption and metabolism in the gastrointestinal tract. So they act locally within GIT without producing systemic effects. Alpha glucosidase inhibitor can be used in therapy to control postprandial glucose. They can be used first at the diagnosis when postprandial glucose level is high. Usually we start with alpha glucosidase inhibitor if metformin cannot be used or contraindicated. They also can be given to patients uncontrolled on metformin monotherapy with high postprandial glucose level, so they can be added with morphine. They also can be used to patient uncontrolled with two drugs and still with high postprandial glucose level. They can add it to the first two drugs used for treatment. We can add the alpha glucosidase inhibitor. The place of alpha glucosidase inhibitors in the management of type 2 diabetes. Usually treatment started with lifestyle modifications. At each step, if not the target is reached, which is HbA1c less than 7%. We start with lifestyle modification, then if not the target is not reached, add metformin, then if not controlled, add sulfonylurea, if not controlled, add the drugs one by one, such as alpha glucosidase inhibitor, dipeptyl peptidase 4 inhibitor, or thiazolidinediones. At the end, if type 2 diabetes is not controlled, the patient were given insulin replacement therapy. Alpha glucosidase inhibitor can be used as first-line drug therapy if metformin is contraindicated or cannot be used. It can be added with other drugs. Pharmacotherapy of type 2 diabetes mellitus. Obese patients, we start with metformin or glitazone. If not effective, add another drug, sulfonylurea, or short-acting insulin secretagogues. If not effective, two-drug combination, then we can add insulin or glitazone if not used previously. In non-obese patient, treatment should be started with sulfonylurea or short-acting insulin secretagogues. If not effective, with diet and exercise or lifestyle modification, sulfonylurea, one drug, then we add metformin or glitazone, and then consequently add each drug, add one drug each step until the end, where the patient requires insulin therapy when the oral hypoglycemic drugs are not effective. Elderly patient with newly diagnosed diabetes mellitus, usually treated with either sulfonylurea, short-acting insulin secretagogues, or alpha glucosidase inhibitor or insulin at the end. Add or substitute insulin. If all drug therapy is not effective, this means that no more insulin is secreted from pancreatic cells, so the patient is required to take insulin. Combination of oral anti-diabetic drugs and insulin. If the HbA1c is not controlled with the optimal doses of combination therapy of oral hypoglycemic agents for 3 months, consider adding intermediate acting or long acting insulin, known as BIDS, bedtime insulin, daytime sulfonylurea. Combining insulin can be combined with the following oral anti-diabetic drugs and has been shown to be effective. Can be combined with biguanides, insulin secretagogues such as the sulfonylurea, insulin synthesizers such as the thiazolidinediones, alpha glucosidase inhibitor. All these drugs can be combined with the insulin in the late stages of type 2 diabetes. Insulin dose can be adjusted or increased until target fasting blood glucose level is achieved. General guidelines for use of anti-diabetic agent. First, elderly non-obese patient. Usually we started treatment with short-acting insulin secretagogues. Long sulfonylurea should be avoided in older patient to avoid hypoglycemia during night or during sleep. Renal function should be monitored because they already have reduced renal function. Oral anti-diabetic agents are not recommended for diabetes in pregnancy. Usually diabetes in pregnancy treated with Oral antidiabetic agents are usually not first-line therapy in treatment of diabetes diagnosed during stress or infections. Insulin therapy is used in these cases. Using oral antidiabetic drugs, usually we start with a minimal dose combined with diet and physical activity. The drug will be allowed to work for, or the dose of the drug should be allowed to work for about 2 ila 16 weeks, depending on the agent used, and then we can increase first the dose of the drug to allow control of the plasma glucose level. Pharmacotherapy of type 1 diabetes. Goal of therapy is to balance the caloric intake with the glucose lowering process, that's insulin and exercise. Allow the patient to live his normal life. Insulin, the administration of insulin should mimic the physiological secretion of insulin in the body. Self-monitoring of blood glucose is recommended for these patients with HbA1c test should be done to assess the effectiveness of insulin. And this insulin therapy for short-term use. Insulin is recommended for emergencies such as acute illness, surgery, and stress. During pregnancy and breastfeeding, may be used in type 2 diabetes. Also, insulin therapy is recommended in marked hyperglycemia, in severe metabolic decompensation such as diabetic ketoacidosis, which is associated with type 1 diabetes, and hyperosmolar non-ketotic coma with type 2 diabetes. Also recommended for use in lactic acidosis and severe hypertriglyceridemia. Long-term use of insulin is recommended in type 2 diabetes when multiple drug or combination therapy is ineffective in reaching the target blood glucose level. Then here we change to multi-dose insulin therapy. When initiating insulin therapy, sulfonylurea or other insulin secretogens, drugs that stimulate insulin secretion from pancreatic cells, should be stopped, but insulin synthesizers such as metformin or thiazolidinediones can be used. Insulin regimes. The majority of patients will require more than one daily injection to control his blood glucose level. One daily injection of an intermediate preparation may be effective in some patients. Twice daily mixtures of short and intermediate acting insulin is commonly used. Insulin regimes or insulin regimens. In some cases, a mixture of short-acting insulin and intermediate-acting insulin may be given together in the morning, with further doses of short-acting insulin given at meal time, that's before lunch, and in the evening before dinner. Sometimes an evening dose of intermediate-acting insulin may be given at bedtime to cover or to control plasma glucose level during sleep. A regime of 3 injections of regular rapid-acting insulins before each meal, plus long-acting insulin at bedtime may be used. Overview of insulin action. This picture shows the types of insulin and their onset, peak, and duration of action. How to calculate the insulin dose required for the diabetic patient. The dose is calculated according to the patient's body weight and A good starting dose is 0.6 units for every kilogram of body weight per day. The total dose should be divided into 2 portions. 45% of the dose for basal to supply for basal insulin level, 55% for the prandial insulin, that is before meals. The prandial dose should be divided into 3 portions, 25% pre-breakfast, 15% pre-lunch, and 15% pre-supper. This is to compensate for the increased blood glucose level following eating. Example, for a 50 kilogram patient body weight, the total dose will be 0.6 multiplied by 50. It will account for 30 units per day. The 30 units is divided into 2 portions, 45%, which is 13.5 units for basal insulin supply, administered in 1 dose or 2 doses per day. And 55% of the dose, that is 16.5 units, for prandial insulin to control blood glucose following meals. The 16.5 units should be divided into 3 portions. First portion is 25%, that is 7 unit before breakfast, 4.5% before lunch, and 4.5 units before supper. How to monitor the blood glucose level. Most type 1 patients require 0.5 to 1 units per kilogram per day. The initial symptoms that can be recorded and the tests can be done include: first, monitoring of the diabetes can be done by monitoring the symptoms for each patient. Second, we can measure patient can measure his blood glucose level by self measuring of blood glucose level. And the third step is by calculating the HB or measuring the HbA1c parameter. Diabetic ketoacidosis. Diabetic ketoacidosis is an emergency associated with usually associated with type 1 diabetes. It results from stopping insulin in type 1 diabetes or increased insulin requirements in such as in other illnesses including infection and trauma. Less common to occur in type 2 diabetes. Signs or symptoms of diabetic ketoacidosis include fatigue, nausea, vomiting, evidence of dehydration, rapid deep breathing, fruity breath odor, hypotension, and tachycardia. Diagnosis of diabetic ketoacidosis diagnosed by high level of glucose, hyperglycemia, acidosis, low serum level of bicarbonate, and positive presence of positive serum ketones. Abnormalities associated with diabetic ketoacidosis include dehydration, acidosis, sodium and potassium, decrease in sodium and potassium, or sodium and potassium. The management of diabetic ketoacidosis should be first management of the symptoms. Diabetic ketoacidosis is associated with dehydration, so fluid administration is required to restore the vascular volume. Mainly it's treated with IV infusion of insulin to restore the metabolic abnormalities occurred, and titrate dose of insulin according to the plasma glucose level.
Potassium and phosphate can be added to the fluid if needed. Metabolic improvement is manifested by an increase in serum carbohydrate or serum pH. Next step in the line of treatment is self-care. The patient should be educated to practice self-care. These include blood glucose measuring, body weight monitoring, take good care of his feet or her feet, personal hygiene, healthy lifestyle, diet or physical with diet, or physical activity or both, identify targets for control, and stop smoking. Long-term cures recently it has been found that diabetes can be managed by pumps which adjusted to the body and release can be adjusted to release the required amount of insulin during basal time and just before meals. Implants, try to new line of therapy, implants and gene therapy by implanting beta pancreatic cells, new beta pancreatic cells to enhance insulin secretion, or gene therapy. Adolescent type 2 diabetes, it has been found that type 2 diabetes is increasing in adolescence. This type of diabetes can be treated with lifestyle modification. If lifestyle modification alone is not effective, metformin can be given in children of 10 to 16 years of age. Gestational diabetes, diabetes associated with pregnancy, it can be controlled by diet. If the blood glucose level is not successfully controlled by diet only, insulin therapy is initiated. One dose of MBH or MBH plus regular insulin in a ratio of 2 to 1 given before breakfast. You can adjust the dose of these insulins depending according to the self-measurement of blood glucose level. Sulfonylureas can be used. They are effective, but they require further studies to demonstrate their safety in pregnancy. Thank you, and that's the end of the